So welcome. We have some visitors today. I think I know who's visiting us.
We're the fan club.
You're the fan. You brought your own fan club.
Well, I didn't even know they were going to be here. I literally ran into Anna on the street, and Terry was trying to coax me with a glass of wine after this. But,
Nice.
Oh, sorry. You said tea. Sorry. I heard what I wanted to hear.
Well, welcome. We're thrilled to have you. So this is Maricel Santos. She's an associate professor of English at San Francisco State. She's a longtime collaborator of many people, I think, here at the General, but Dean Schillinger, and she is a co-investigator on our Charm Grant. And you're going to hear a lot of wonderful work that Maricel does with ESL teaching, and what we are particularly interested in, of course, because we come from the health perspective, is the relationship to doing education in the diverse communities that we're interested in.
Absolutely.
So we're thrilled that you're coming. You came here to talk to us about our work, and we'd love to hear more.
Yeah, so can I just do a quick around,
Yes.
what your positions are, and also because you guys don't know who those folks are, which is important to know.
Sounds great.
Yeah, so.
So I'm Kirsten Vivens-Domingo. I direct the center here, and I'm a general internist, and I do mostly work in cardiovascular disease epidemiology.
Hi, I'm Christine Dellendorf. I'm a faculty member at Family Medicine, Research and Disparities in Reproductive Health. And I'm Brittany Wiles. I'm also a faculty member here at Internal Medicine, and I research guidance prevention broadly.
And I'm Diana Martinez. I work with Margaret Huntley in his current gestational diabetes intervention project.
And I'm Purva Chatterjee. I'm the manager for the Center for Vulnerable Populations and as well as a manager for the Charm Grant.
I'm Ana de Carolina. I am the English program coordinator at UCSF Seminar Series.
I'm Terry Maston. I teach ESL, vocational ESL, and I'm the vocational ESL resource instructor at City College. I work with Maricel and
I'm Judy Kwan, and I'm a statistician for Initial Winter and Readiness.
I'm Nita Calza. I'm in GIM, and I do research on patient-provider communication and medication adherence, and on electronic health records, how that affects communication.
I'm Pam Lane. I'm one of the faculty here. I lead the project as part of this Charm Grant on tobacco prevention among young adults.
Hi, I'm Bob Hyatt. I'm an epidemiologist and an internist, and I'm, for this Charm Grant, the director of the research core, and I'm chair of epidemiology and biostatistics. And my sister teaches ESL in Charlottesville, Virginia.
I was going to say my mom teaches you.
Maryland.
I'm Gata Gorley. I'm a project coordinator with the Center for Vulnerable Populations and on a project spreading innovation between California's public hospitals.
Hi, Pam Coxon. I'm a mathematician, and I work with the cardiovascular disease policy model.
Okay. So, hi.
Come on in. Bring chairs.
Here's a chair over here.
There are chairs over here.
We'll just sit back here.
You got to introduce yourself, though.
Okay.
Hi, I'm Nazarene. I work in the Wellness Center on 23rd Street at the hospital.
And I'm Blue. I also work at the Wellness Center, and I run the care program for cancer.
Wonderful. Thank you for coming over.
We appreciate it.
No worries.
And may I add, we also run the patient ESL class at the hospital, so we're really interested in learning more.
Oh, that's so good.
So am I. Okay. Well, I'll have to be really honest. I've been moving for the past month, so the idea of having to give a presentation now is I'm just relieved not to be surrounded by boxes right now. So this is refreshing. But I'll just say really quickly, whenever I get to hang out with Dean or Margaret and colleagues, I'm always sort of reminded of how I think about my own career, and I am now self-identify as a literacy researcher. But I find so many interesting things in the things you guys study when it comes to community work, community-based epidemiology, community outreach that I think had I had a different kind of mentors around me, I might have ended up in a public health field, but working with ESL teachers and literacy, because I find so many points of connection. And I hope that by the end of our time together today, you do as well, and are just sort of more affirmed in that commitment. We're really at an important time in this country. We're coming off several waves. We're now on our 4th cycle of international survey assessments, which are telling us the same sad story of what the literacy levels are in the United States. The sadder news is they don't seem to be improving, and the opportunities for adults with low literacy skills to accelerate that educational trajectory also seems to be diminishing. There's a shift in our current educational administration to rethink workplaces as places that you can also develop skills but at the same time having meaningful employment. And I guess that's a good analogy for us to think about in terms of healthcare. If you think you've got a task to do, you've got healthcare decisions to navigate, and it shouldn't be demands placed on you literacy-wise. They should also be opportunities for you to be developing new skills along the way. And so as educators, we consider that our premium responsibility to be able to identify what those transferable skills are. So the message that I like to bring when I come to settings is to talk about harnessing the adult ESL classroom. And I know Dean, I'm not sure who used that verb first, he or me, but we talk about harnessing the classroom. And to harness something, you have to understand what opportunities lie there, and also to understand the outcomes that you can expect reasonably from the engagement that you invest in those settings. So one of the things I'd like to just highlight today, based on some work we've been doing over the past 3 years, is to talk about why the classroom is a place of readiness and capacity, and not to think of ESL projects as separate projects that augment the work you do here at CHARM. But my vision would be that the ESL component should be woven in to many different projects. In the same way Margaret and I used to talk about the IRB, you check it off, you make sure that you've gone through certain processes, thinking about putting yourself through a checklist of ESL conditions, ESL goals. And when I say ESL, I'm just talking about, have we connected in the most optimal way with the adult ed environment? I say ESL because my default is to think about the immigrant learner, but a lot of the concerns we're going to raise today also apply to adult basic education environments where you find individuals who are African American, also need basic skills, and longtime residents of the U.S. who are orally proficient in English but still lack skills in written English, which then defaults them to an ESL environment. Just a little bit more about me. I'm at State. On an everyday basis, what I do is I train ESL teachers. So Terry, I found Terry's dissertation, or your master's thesis, in my move the other day. I should have brought it. And Anna did her MA thesis under me when she was at State too. So my primary focus is on an everyday basis training ESL teachers, which means I'm in the throes of thinking about pedagogical science and as a way to convert content into transferable skills. But my route into the public health world, into sort of areas that you guys are connected with, was through Rima Rudd. When I did my doctoral work back on the East Coast, she was affiliated with the National Center for the Study of Adult Learning and Literacy, doing health literacy work, specifically this component called the Health Literacy Study Circles, where it's one of the first pushes to try and get health literacy into the vocabulary of adult educators, to make them feel comfortable with this term. And then since then, when I arrived out here at State for about 5 years, I was a research fellow with the REMI, which is a National Center for Minority Health grant to minority-serving institutions to try and increase the kind of health disparities research doing at places like the Cal State system. I'm going to say health literacy a lot. I'm going to say literacy a lot in this talk, but often I feel like when we say this word, we're not quite sure how to relate to it. And that's even true in the world of education. You may remember perhaps from when you learned how to read the phonics wars, and how there was a great emphasis on, no, you have to learn the alphabet and how to decode first. And then there were other people who were screaming, no, you need to be surrounded by meaningful text. And all of those bottom-up skills will come naturally if you're engaged with text. Well, as it turns out, after about 20 years of fighting, both matter. But in the same way, I think, even though there is a similar debate around literacy in the reading world, in the literacy world, we really haven't engaged in the same kind of debate in this country around health literacy. We have defaulted to a definition of health literacy, which I think does not benefit from the great advances that we have made in literacy studies. And I'm going to introduce some vocabulary to you today that will help you wrap your head around what I think is conventional, standard, very useful, foundational in our study of health literacy in this country. But also its limitations, and why the adult ESL world is teaching us to think about literacy in a broader way. You know this definition. You'll see very quickly that these 3 levels of action: to be able to access information, you need to be able to obtain it, process it, and then make decisions with that information is the functional definition that we've been operating with in this country. We also know that there's a context in which health literacy skills are put into practice. So even though we tend to think of individuals having a repertoire of health literacy skills, you enter into an environment and the context places certain demands on you. So even the most functionally literate person may look dysfunctional if the demands are too great. And without the proper amount of supports, those who are lacking in literacy skills look even worse. When I teach my own graduate students about literacy, we like to make a distinction between literacy as skill and literacy as practice, and that's the analog here for thinking about health literacy today. Health literacy skill is your conventional definition, thinking of it as reading and writing skills, being able to get information off print, off text, and putting those skills into use independent of the context. Reading a sentence on a pharmacy package is pretty much the same skill as reading a diabetes brochure, is pretty much reading the same kinds of skills for reading different kinds of charts and forms. It's all basically the same kind of decoding comprehension process. That is what we used to think in the 70s and 80s. And as we've gotten more in tune with how people actually put their literacy skills into practice in everyday context, you realize that the alphabet, knowing the alphabet or knowing basic comprehension skills are insufficient, which opens up this idea of literacy as practice, which shifts our attention to what people actually do with their reading, writing skills, and the activities and the processes that give meaning. So the best example I can always think of is when you go in and you have some sort of outpatient procedure and you're handed the HIPAA form. No one reads it, right? You sort of have a symbolic understanding. You could, if you wanted to, and most of us who are highly educated would have a fighting chance of comprehending, of obtaining, processing, and comprehending the significance. You might even understand that this document actually protects the hospital more than it protects you. But that's because you understand the meaning or the significance that gives its meaning. But what's interesting to me as a conversational analysis, as a researcher of literacy in action, is I like to see the conversation between the two people. You know, they hand it to you. So what are you here for today? I'm here to have a gallstone removed or something. Oh, sign this form, and then you go over there. And this whole navigation behavior starts happening. So one of my favorite quotations from the literacy world is, texts matter, but talk about text matters just as much. And so it's suddenly, by shifting it to practices, you're able to look at least for me as a literacy researcher, I'm looking at the oral communication that is giving significance to what's print. And it's impossible to separate the comprehension of that document to its symbolic value and the social interactions that happen around it. Just to fast forward really fast, this is really messy research. This gets people really upset because you need a whole battery of assessments, a whole battery of ethnographic tools to understand literacy at practice. Whereas if you want to focus on literacy at skill, there's usually a comprehension test you can give. So making these choices to broaden the view definitely brings up questions about methodology that we can talk about later. So here is just so you have a sense of where this is coming from in the literacy world. When we say literacy is social practice, we are very preoccupied with what is the social activity? Well, I'm registering for an outpatient procedure. What are the conventions, the structures, the expectations that are associated with it? That's what we start to inventory and try to wrap our head around versus what's my reading level, what's required by this interaction. So it's a slight shift. And I think it's subsumed. It's not like we've abandoned the first view, it's that it's become enmeshed in a broader view. But also the ideologies that inform the behavior. There are some areas in the world where you don't sign a HIPAA form because it's irrelevant to that particular interaction. I've always thought I should move to Australia to hang out with people who think like this more often. Donald Nutbeam, which is a crazy name, but I guess he gets away with it, has divided it in terms of thinking about functional is the IOM definition, interactive gets more at the social activity that's taking place. The critical dimension, for those of you who are familiar with the Paulo Freire model, is the idea that the third level is what happens when the first two break down, or what happens when you don't like the information you're given, or it's at odds with what you were expected. How do you reverse direct the communication in a way that works for you? So I once asked ESL teachers to look at this picture and say, tell me the functional, interactive, and critical literacy skills that might be at work. And the first person said, well, that's the former vice president of George Bush asking for his medication. And we never got past to the exercise.
Cheney.
Yeah, Cheney. Gosh, I blanked on his name. Yeah, Cheney getting his
Easy to
medication.
forget.
Yeah, so, but I can ask you, I mean, what's a functional literacy skill at work in this picture?
Reading the medication.
Okay, reading the medication label. What's an interactive piece?
She's explaining it.
She's explaining, he has to understand, okay? So he has to, we think of immigrant learners as, you have to have discourse competence, which it means you have to ask follow-up questions. So it's to be able to sustain conversation. It's not only just to initiate, what does this mean, but it's what if you don't understand the answer, how do you sustain that discourse? And then the critical piece is, you know, as many of us can recognize, what if you don't understand? What if you walk away with the wrong prescription? What do you do? What if you think, oh, that's not the medicine that my doctor told me I was supposed to have when I got here, etc. So this is just a restatement of two things. One, I don't want you to think that these are competing, that you have to choose, that I'm a literacy a skill person or as a literacy a social person. I think our country is prevailingly literacy a skill focused. It's easier. It lends itself to assessment, and that's even true in the education K-12 world. But the broader view is to absorb that within a larger model. So one way to think about it is what does each of these perspectives buy you? Well, on the one hand, we can think of, if I can get you to appropriately access and make decisions on the information that I give to you, that's going to translate into improved clinical care. Well, what are some outcomes that matter on the other side, which is improved navigation of the system, perhaps improved confidence in your ability to interact in social activities, and changes, positive changes in oral communication patterns. And for us as ESL teachers, this is the holy grail. If I can expand the repertoire of social interactions you can have on a daily basis, that's a different goal than thinking about, oh, what vocabulary and grammar skills am I going to give you this module? It's, have I expanded the kinds of oral communication activities that you engage in? Another way of rethinking about this is the skills view has often led us to a default of what people don't come into the situation reinforced with. What skills do they not have? The practices view enables us to be more embracing of what robust strategies people use in compensatory manner when they don't have reading, writing skills. And I think you can ask our ESL teachers on a daily basis, we see ways that people navigate environments despite. And it's that despite that gives us our deficit language. The practices enables you to abandon that deficit language and say, how is health literacy both a social and a cognitive outcome, which results from a lot of interactions that happen in a formal context, let's say your ESL patient clinic, an ESL classroom, but also at the kitchen table where you're exercising what you may have learned from some other context. These are just sort of sound bites that I think if you're leaning towards the health literacy as a social practice view, that you'll hear in the literature, that we're not just talking about the language, which means translating into a better brochure, that proficiency, increasing proficiency is no way a guarantee of successful social interaction. And that the ability, it's not only your right to speak in certain, under certain conditions. I was just out in your lobby listening to those films. I mean, I think it's all about not only the right to speak, but it's the right for those youth to impose listening on others about their perceptions of diabetes. And that's a different way of thinking about where does the power lie in these social activities. Years ago when I started working with Rima, and we started thinking about what's the best way to nurture these relationships between public health and adult ed, she back in the 90s called it a maturing partnership. I'm not sure where it is in its maturation. It's sort of fizzling right now because there's not an incredible amount of attention. There is some funding coming out of NIH, but the focus on the adult ed world is not as emphatic as one would hope. And in fact, at the time, our early thinking was, let's make sure we don't cross boundaries. The doctors will do what they need to do. We don't want to get into any kind of content. You'll talk about the diabetes content. We're going to identify the transferable skills. So what we're going to teach is probability. We're going to teach document reading, chart reading so that they could read the labels. We worked very hard to try and keep it very separate. It wasn't a very sustainable model because at the end of the day, the student's going to raise their hand and say, can you help me read this pamphlet, or can you help me read this brochure? So it was, in theory, in terms of teacher practice, it was a good model, but when the rubber hit the road, it was not working. And a lot of frustration from teachers came back saying that they didn't feel as prepared as they thought they should be after engaging in a study circle. So my current thinking, I am a classroom researcher in my researcher heart, so I spend a lot of time looking at the kinds of interactions that are happening in classroom that would support the discussion of health content in a way that wouldn't place unnecessary burden on the teacher, but wouldn't expect there to also be a partner, a doctor coming in answering questions. And a part of it is shifting who's asking the question and where they feel like that resource, where those resources are in terms of their ability to ask questions. So these 4 bullets sort of describe my view on why ESL classrooms are important places for public health literacy research. First, we have this idea of classrooms are safe spaces. Now, this is not magically true. It's not like Terry starts her class and everyone just automatically trusts her, even though she's a very warm and open person. But it is a process that happens. But by comparison, I've seen this a number of times, for example, with day laborer learners, the kinds of questions that get asked in ESL classrooms defy what you could ever hear in the mobile clinic. And part of it is perhaps the idea that the ESL classroom is a place where it's okay to say you don't know. It's one of the first sentences you're taught on day 1 to ask questions. One of the first things that we are taught are the series of how to ask questions to clarify comprehension. And display shared expertise. So you don't know, but I know something, she knows something, and together we know 2 things. There's very normal pedagogical routines that make that a standard part of the classroom process, as opposed to in a clinical environment, you're on your own in many cases to be able to shore up your own individual resources. As in the example with the day laborers, you have a lot of access to communities who are often hard to reach. And I mean that even in the transnational sense. If you walk into any city college classroom where you have 20 different backgrounds, those are transnational environments that aren't even replicated in other areas of the city. But you have this cross-cultural sharing, this transnational sharing probably more appropriately, globalizing patterns of how healthcare information is being shared is sort of a unique phenomenon in of itself. Links to existing social networks within marginalized communities. Perhaps most related to some of the charm work where you're trying to reach out to 16 to 25-year-olds. We have a growing population of 16 to 25-year-olds in the adult ed world. They used to be kept in high school, and now they're being shuttled out. And so there are these teenagers ending up in adult ed. And so this idea that they're not being reached by K-12, but they're sort of floundering in adult ed too. So it's a community that I think I'm excited to see a part of the projects here. And so I'm going to show you in a few other examples later. Learners also have the opportunity to explore social positioning that may not be available to them. So this seems so banal to us as an ESL teacher, but for them to practice how to speak to a pharmacist is exploring a role that they may not ever have an opportunity to practice in the real world. Or even to imagine 5 years from now, what kind of conversations do you want to have with your children about nutrition at the kitchen table? Exploring those roles become the part of the content that I think are very much within access for adult ESL teachers. You may not know very much. I know you have some relative connections to the adult ESL world, but I'm always impressed by the numbers of the adult ed system given the relatively little investment in this system. About 45% of the adult ed system is adult ESL, our immigrant communities. 72%, almost 3/4 of all the adult learners in the state of California are in our ESL programs. And in City College alone, I think this is a number that's actually a year old. It's probably higher now. Despite accreditation fears, you have about 35,000 ESL learners going through the City College system every year. Sort of just a restatement of what I've been talking about in the past 3 slides. There's an evaluation model out there in public health called the Re-AIM project, and when I worked with some ESL teachers, we glommed onto that because it gave us some vocabulary to be able to talk to public health. That the reason why we think the ESL classroom is harnessable is that it gives you reach, it gives you opportunities for engagement, and it gives you tools to make both of those processes put into play. Are you familiar? You must be familiar with the Re-AIM model, yeah. So those come very similar from that model. But again, that's just a restatement of what I just said. So the questions that I'm left, and I'm going to just pause and see if you have any questions after this slide. These are the overarching questions that whether we're talking about lead poisoning, which we did in 2008, whether we're doing mental health with men in the day laborer programs in San Francisco, or now diabetes, these are the overarching questions that seem to guide us as we think about what kinds of tools we want to develop, what kinds of teachers we want to work with, what are the outcomes we expect. Who are we reaching? And you can say, oh, well, we're reaching people who are not proficient in English. It's obviously a lot more complex than that. You also have a self-selected population, a self-selecting phenomenon that's also going on that invites some question about who are the learners that are coming to our ESL programs, and how does this become a dissemination network? In what ways does an ESL learner-initiated model? What happens when information comes into communities through the ESL program first? How does that create a different kind of reach, a more expanded reach that blends language and content to vulnerable populations? And in what ways does there have to be customization? In what ways does work in City College and the Mission going to look different than City College in Chinatown, for example, as you think about local identity? So I'm going to pause there and see if you guys have any questions or clarifying. Yeah.
Hi, Maricel.
Hi.
Great
Yeah,
to
see you again, yeah.
So I'm really interested in technology, and I'm wondering over the years that you've been doing this, how have you seen the use of technology in learners change?
Yeah, so Actually, this is in terms of technology, I think I mentioned this when we were down in San Diego last year. There's a national project going on right now trying to digitize the adult ed world because it's very behind. And the divide, as you know, is no longer access. Everyone has access now, but it's the quality of the access. And you see that in public schools. Kids in inner city public schools are basically doing workbooks on the computer. So it's still the same drill and skill. It's not creative, it's not expressive, it's not interactive. Whereas kids in middle class environments might be creating PowerPoints or interactive slideshows. If on a spectrum of those kinds of behaviors, I would say in adult ed we're probably here in terms of are we allowing it to expand the possibilities. When we asked day laborers what media would they like health information to come for them, many of them said either a DVD or I want some messages coming to me on my phone. So at least there's a request for it, but I think it's still at the level of access versus a way of communicating, the way you can now communicate with with a doctor via email. So I think you're for the most part you're thinking about a lot of adult ed programs that are under-resourced and don't have computer labs or can't use that in a way that's transforming the way you can present education.
Are they coming in with cell phones? Do they, is part of what they're asking for, like, I want to be able to use an iPad, I want to be able to use a computer?
Yeah, Anna, we were just in your class, and I would say even in your class of 12, only half seem to be comfortable with the idea of email or...
A lot of people use smartphones, but not everyone has an email account. So they're used for other purposes. And so yeah, access is still an issue for some of our population.
I've always wondered, it's not health related directly, but your point about being able to interpret having somebody there to help interpret the text is interesting, because one of the things that struck me about voting, how do we vote in this democracy? At least in California, we read propositions and pros and cons. So some of those arguments are pretty complicated. And for people that don't have are not literate, and there's nobody around to explain things, that must be very difficult.
Yeah, in fact, the empirical data that supports that is in the latest international survey. They showed at lower levels of literacy, you exhibit lower levels of trust of public information. The level of social trust is diminished. And so, there is an opportunity for intervention. In what ways, if you boost social interactions that can facilitate trust, despite lower levels of literacy, might you be more receptive to the kind of information? And I think some of the digital work, especially for your 16 to 25-year-old crowd, might be a really productive answer there. So where we are now with this diabetes project is a little sad. It was a 5-year project, got halted at year 3. But it was enough to bring Terry in for 2 rounds. Terry was with us from 2008 to 2011. And our goal at the time was we wanted to convene a task force of ESL instructors, increase their awareness of key messages about diabetes prevention, integrate that into the curriculum, have disseminable curriculum, but also have cadres of teachers who would feel comfortable working with other teachers, like in sort of the train-the-trainer model. And then also be able to assess the impact of the lessons. Because of the abbreviated timeline, we didn't reach out to, we were supposed to reach out to 1,000 learners, but with the final 2 years cut, we weren't able to do that. In talking to teachers, why do we want to be in your classrooms talking about diabetes? We came in with 2 messages. Not only is there great risk, talking about the health disparity statistics, but we said we think this is an opportunity. And I think that impulse plays out in a very interesting way, as I'll show you in a little bit. When we talk about opportunity, and I've already mentioned a few of these, we know these things to be true. Some learners already have healthy habits. Some learners are motivated to talk about health. I think any needs assessment you do, what would you like to or learn English for? Health is always one of the top three. The number 2 is to find a job, and the 2 is to be able to talk to my child's teacher. Again, this idea of safe spaces, and the piece that I think Terry and Anna can speak to most clearly is the ability to use interactive and critical methods to foster engagement and social support. And here's the crux. The things we do are not rocket science. I mean, using meaningful stories, using meaningful videos. I mean, if you think about the methodology that goes into a video, it's a very basic idea. But I think the complexity is, how do you integrate the content? What content matters? How do you sustain that interaction? How do you sustain interaction in sort of a hypothetical sense? This information might be useful to you. I mean, that's an expectation that any of us bring to an adult when we're learning anything as adults, and our learners are no different. We talked to about 140 teachers across the state and asked them, are you ready to do this? And here are some things they told us. Yeah, this is really important, diabetes is really important, but with a lot of state-influenced expectations, there's not enough time, there's not enough flexibility in our curriculum. I can't get my boss's approval, even though I think this is important. I don't have appropriate enough materials, especially for beginning level learners. A good 40% of the teachers that we ended up speaking to are working with recent arrivals and individuals that have less than 6 years of education. That reflects just immigration trends in California in general. But that is also the same, that term reflects here. The teachers wanted to know more. We asked them, what websites do you go to? And a lot of them said WebMD, but they didn't know of other things to go to for reliable information. They were concerned that learners might not be interested in diabetes if they were coming to actually study for the TOEFL or get a job. Diabetes might not feel so relevant. A lot of them were concerned about, I don't want to be in a position of telling them how to live their life, even though I see the Gatorade bottles every morning on the desk. I don't want to feel like I'm telling them how to eat and how to drink. And that has also to do with learner privacy. But the most important thing that came out, these were not new concerns. I mean, I think there's a lot of issues, social issues that come into the classroom that this is also relevant. But there was interest, there was concerted interest that they could do this, and that it was important to bring to the adult ESL population. I show you these pictures only because Terry's in one of them, and Dean is in a couple of them. These are the teachers that we had all the way from Bakersfield and Monterey come up and join our task force. 2 years later, we were much smaller, but Karen Omar, whom you may have met through the Cal Diabetes program. And I know as part of the CHARM project, the idea is to create some sort of network of teachers. And so this was a model, I think, of what could have been started. I think the idea of having a coalition of teachers who feel equally armed with health literacy tools, connected to individuals like yourself. I mean, if you just map by zip code the number of health clinics and ESL programs, there's almost a one-to-one overlap. And to see that as the network that's already emerging around where you already operate is sort of network is already mapping itself. In terms of opportunity, Terry helped. Do you remember collecting this data? You were the one who ran this focus group for us. These are starting points for personalizing health content. They may not be accurate. You may feel that, oh, there's education that needs to take place here. As from the pedagogical standpoint, we see this we call them gateways. We allow these to, well, who else thinks this? Where have you heard this before? What would you say to someone who said this to you? We have the time and the ability to put patience into the process of suspending talking at and really exploring the conversation that can happen around this. So these comments like these led to about 45 minutes of conversation with level 4 learners at City College. I'm just going to skip ahead here just to pick up on that last thought. We have lots of materials around diabetes, mental wellness, nutrition, that personalize the health content. And that is sort of one of our pedagogical premises. It comes from a colleague of ours who passed away, unfortunately, a few years ago, Learners' Lives as Curriculum, which is all about, for an educational process to hatch, you have to personalize the content. You have to meet the learner where they are. And finding stories, like your videos, I think, in your lobby, it's the same, it's the exact model that we're working with, become the gateway topics. They become a basis for thinking about change, struggle, collective resilience, collective healing. But then the teacher, the trained teacher, can come in and say, I can see lots of opportunities for developing language, literacy, numeracy, health literacy skills that give character around the story so that it's not just the magical sharing, because that is insufficient. The science, the pedagogical science, comes in where you can convert that into really accruable language and literacy skills. Here's one of my favorite stories that was used quite successfully with women's groups, women's ESL classrooms. It tells the story of women who live in Oakland who would sit on the sidelines and watch their husbands and brothers play, and they decided one day that they wanted to form their own soccer team. At first, our husbands coached us, but they either yelled at us or even laughed at us, so we started practicing on our own. Then we found some better players to join our team, and now we're a lot better. And it's a really great story as you think about one of the precepts of how do you beat diabetes, is finding sources of social support. So as we drill down on, you're not seeing 1,000 learners, you're only seeing 150, but drawn from 5 ESL classes of all different English proficiency levels, language backgrounds, and educational history. We had every one of them take the ADA test, and maybe I'll let Terry talk a little bit about what it was like in the classroom to have the students take the ADA, a simplified version of the ADA. This number was kind of surprising, that 54% expressed intention to change their exercise or nutrition habits to become healthier. But that means about half didn't. So our sense was that a lot of our learners were coming in already feeling that their habits were healthy. So in terms of that idea of risk, we think it's important to think about the adult ESL classroom. It's not just a place of where people are sick or about to be sick, that it's a place of potential leadership, potential models for healthy habits that can get disseminated to areas where there is some real, very real vulnerability. And that this idea of most students reported sharing the health information is an idea that there's a diffusion system here that starts from the classroom. So one of the things that I like to think about in sort of the next few years here at CHARM, and I'm affiliated with this gestational diabetes project, and also the youth piece. And in the spring, we'll be starting to design a project that will reach out to youth classrooms, where you can bring the diabetes message. And so one of the ways that these are the things that will sort of guide our thinking is thinking about those multiple levels of literacy, skill, and practice that are guiding your work, that are at work already, and therefore need to be, are ripe for intervention. Thinking about ways that engagement can happen. And this is where I really think the partnership with the ESL teacher could transform interventions, because you can really think about scaffolding and therefore making it more meaningful to the learner, because they're not only developing content knowledge, but they're also developing language and literacy skills that they're interested in as well. And as I'd like to think that when I do get my R21, we'll be educating folks at NIH that different kinds of outcomes are important as we think about the not learning processes are important outcomes here as you think about the educational piece in health literacy. I just want to end on last piece, which is a picture, which is kind of where we are now. And if the projects that I work on with CHARM in the next few years can help suss this out a little bit, I'll be forever grateful. But this, just let me orient really quickly. All the orange arrows are things that I think we know very well and have a lot of science to back up in terms of what supports health literacy and what leads to health literacy outcomes. The things in yellow are the ones that I think deserve more empirical investigation. And so this is where this idea of health literacy sponsorship network really tries to get at the idea of literacy, health literacy as a social outcome. That a measure of your improved health literacy is a more fortified social network in which you carry out health literacy tasks, and that we can use a lot of social network analysis to measure. And in making the ESL world a central piece as perhaps the incipient point of a lot of directionality. And so the idea of thinking about how these networks passing through the ESL classroom will provide that greater access and meaningful engagement is the model that we're going to move forward.
Wonderful.
I'm going to stop there.
Thank you very much.
And if you have any questions for these two teachers in the past year have actually used the diabetes literature, the diabetes lessons in their classrooms.
So I would think that diabetes is a great health story because it's so common. And probably everybody in the classroom is touched by it in some way. So you can relate. Well, I'm really just guessing, but it's really a question. So do you find that most people in the classroom can relate to the disease and its problems and who's affected in some personal way?
I'm thinking of what you just told me 2 days ago.
Yeah, actually, in my classroom, most of my students, either some of them have diabetes or pre-diabetes, or someone in their families have diabetes. And I found out about this even before partnering with Maricel in my previous classes. I heard about it all the time. So it started to be, something that concerned me, and then I started this collaboration and in the classroom, because it is a safe space. We were able to listen to all these stories about diabetes and their diabetes and how prevalent it is.
And so you could think about other things that are common, like cardiovascular disease, or cancer's not so common, but cancer stories permeate the population pretty deeply. In rheumatoid or arthritis, not rheumatoid, but osteoarthritic problems. I would think
yeah.
a lot of different. You could sort of translate this into a lot of different examples and stories.
Although the work we do is to usually one of you guys approach us and says, oh, we have this grant to reach out to immigrant communities on this particular health issue. And then our job is to think about, well, what would be a good modular theme? And so let's take lead poisoning. I mean, it's not such a sexy theme. I mean, and if you call the ESL module lead poisoning, you might not have very many takers. But the day one question for us is, what poisons can you see and what poisons can't you see? And it started this conversation of, the time I got bit by a scorpion and the time I ate that plant, to the things that are in the paint in the walls and when the paint flicks off. And what it did is that it normalized conversation so that in a couple days people were saying, yeah, remember that time I ate that clay because I thought it was satisfying this craving, and I was told it would be good because it would be a good source of iron. It normalized, I think, a conversation about where sources of lead might be. And so the gateway was not lead poisoning. The gateway was everyday poisons. And that, I think, that's the pedagogical choice you make, to see where that the gateway topic opens the door for conversation.
I've been thinking a lot recently about diabetes stigma, and because one of the things I thought was so interesting is Tom Hanks was diagnosed with diabetes, right? And then it was always like, what did he do to get diagnosed with diabetes? And it sort of made me think about how different that was than Angelina Jolie having a double mastectomy to prevent herself from getting breast cancer, or other celebrities' cancer stories. There was so much more. It was discussed in so much more of a patient-blaming way, frankly. So I'm wondering what has come up about diabetes stigma when you guys have done these lessons.
Well, it's interesting because we have very different populations, because there's monolingual and monocultural and different parts of Latin America. And I have a completely diverse population. And I also teach doctors and nurses that come here, they've been trained in other countries, so they're in the class with just people who want to study that. So it's interesting, we had this conversation about, we were talking about the article about smelling cancer, ovarian cancer, that there is new studies that if we could feel that, if we could smell that. So I brought that up in class, and we just started talking about smelling a disease. And everyone started talking about like diabetes, how people can smell, you know, in urine or in their, you know, in their bodies. And people were telling stories from Yemen and from Russia, and like they were sharing these stories, and it wasn't, weren't talking about how did that happen, but they were sharing stories about how they felt about it. And it was this completely diverse population that they were comfortable just sharing these very intimate, you know, stories. And one of them was, one woman was talking about how she feels like her whole body smells different since she's been here from, I think, from China. Like she feels like her gas when she passes gas. She never passed gas before. Now she passes gas, and she's.
It's the microbiome.
It was a very intimate. I was just thinking about how intimate of a conversation it was, and there were like different ages and different cultures and different levels of you know, knowledge of health, and so we were more talking about that than, you know, how did they cut, and they weren't even embarrassed talking about that. So I think there is this level of like comfort.
Yeah,
and,
we did.
Ease.
One thing, you might want to talk about you brought in a role model, somebody who had been pre-diabetic, diagnosed as pre-diabetes, diabetic, and then she was able to, she changed her life. But we before we did the ADA assessment, we had this worksheet with just profiles of different body shapes, and we just associated different risk markers. And we just asked the students, who do you think has diabetes here? And the punchline was that everybody did, just based on genetic history. And it sort of, it started the conversation, and actually that was important in some classes before they were willing to take the ADA test and share the results in class. That was a huge, maybe not so much in your class, you remember, but not everyone wanted to share their ADA results. So they were given a fake person to do the ADA risk assessment on. But it was because of that activity, I think, we were able to get the results of most of the students. Yeah.
I was interested to learn more about the cultural breakdown and the language background of the different adult learners. And you mentioned something about there being a lot of youth that are now being part of the system. So I'm curious to kind of hear how people's educational, or how people's cultural background really played a role in how they felt about these issues. Some of the work, and I'm happy that Ramala brought up the stigma, because it's something that's been happening a lot in the Diabetes Friendship Project we do with youth, is that it's the first time that they're talking about it with their peers, and it's the first time it's becoming a conversation topic. And one of our messages that we've kind of moved towards is this whole idea of you're not alone, because people have felt so stigmatized and ostracized, and really, but then you learn that everyone's personally touched by it. But also there's that cultural component where, you know, people feel differently about it in Mexico than they do in other parts of the world because of their cultural background and their food culture and how that changes when you immigrate. So could you speak to that a little bit?
Yeah, so first of all, I think it's just important to recognize that the youth have a very awkward position in adult ed. So I'm not even sure that we have a clear answer, because we don't know what to do with our youth population in the adult ed world. They're not supposed to be there. They're supposed to have, you know, gone through a K-12 system and then gone on to community college or college, but now they're in this place. And one of the challenges is the intergenerational disconnect. It's not cultural. It's often the intergenerational disconnect where you're trying to do group work by putting a 16-year-old with a 70-year-old grandmother and trying to pair them up, and the teacher has to be sensitive. Sometimes it works, I think, but it requires a lot of attention to appropriateness. But no, I don't think I think that's what's exciting for me in the spring, to try to figure that out, because we don't have very good curriculum. The standard is to default to slightly older parents, and the idea of a curriculum that could engage youth in an adult ed class doesn't exist right now.
So are they right now in their mix? And can you give us, I'm sorry to be ignorant on this, but give me an idea of how long a curriculum would be, and
Yeah, so it depends on the kind of program you end up. A place like Terry's, who's associated with the City College, they're on a semester system, so about 12 to 15 weeks, depending, 18 weeks. But they have a start and an end. A community-based program operates on a 7 to 8 week cycle, and the frequency of sessions will really vary. On average, 5 to 10 hours, or it might be 3 hours total, 4 hours total per week.
And then give me an idea, how did you integrate the diabetes focus into that curriculum? Was it?
Well, we got teachers who were willing, who had taught different levels,
Right.
who were willing to learn the curriculum and then, present it in the class. I don't know how.
We chose.
So was it throughout then, this entire set of sessions?
No,
Or was it
so
one
no, so
specific-
none of the
is it-
interesting.
So would
yeah.
that be 1 or 2 sessions, or?
None of the teachers could devote an entire semester
Sure.
to diabetes, so they chose. We went with the hour. We thought 12 hours. 12 hours is something a teacher could reasonably devote time to. So we gave them 12 hours worth of material.
I see.
And they adapted it
to
whatever fit their level and the students' needs.
This makes me think of another diabetes study that's been carried out at Kaiser with a guy named Andy Carter that Kirsten knows. And they have like 150,000 diabetics or something that they have in a registry. And working with Nancy Adler, who's a health psychologist, they've looked at the Epidemiologic Association of Education with diabetes, which is fairly strong, and asked the question, what does education mean? Does it mean, because the way it's measured in their surveys is, have you completed high school or college or part of college or whatever? And that could mean all sorts of different things. It could mean that somebody's actually more informed. It could mean different things depending on which country they were educated in to start with, immigrant issues. It could mean something about literacy. It could mean something about being smart about access to services. And they're trying to deconstruct this relationship. And I don't know the answers, what they've come up with, but it strikes me that there might be some interaction. Margaret must know Andy as well. But there might be some interesting interaction between what you're doing with ESL and literacy and diabetes with what they're finding in this huge population related to education.
Yeah, I think that also would open up conversation about how might a social network provide the moderating variable for, despite low levels of education in the kind of this formal way, how can you be very, very health literate, very successful?
Yeah.
So then when you say there is no model for youth, so are these, youth is sort of like, there's a broad age range that people are talking about. Are these youth integrated in the ESL classroom? Are these young people who never had an interaction with the public, with school systems?
No, they have and they had to drop out because they couldn't pass the California state test.
Got it.
So that's happening. That's probably the prevailing model.
In City College, I don't think we have that many people under 18. They are.
What about non-credit or credit?
I could be wrong. Not in my classes.
And I think because you're with the career-oriented classes. I think they're Massachusetts we saw a lot because the stakes were quite high in the high schools. Another reason why you might not see them is because you're not in an adult ed, in a unified school district-based supported adult ed program, where if you didn't finish at the high school, you could just go to continue at night.
Got it.
Yeah, so that's probably where you would find them.
I
Yeah,
see.
like Smart down in San Mateo.
City College is that.
Sure.
Yeah. Yes.
I just wanted to comment, we have this wellness program at San Francisco General, and we initiated last spring a program called WOW ESL, working on wellness, English as a second language, and worked with a wonderful teacher, Lynette Escobar. I don't know if you know her, but we got her through the Newcomers program. One of the big challenges is, we plastered the whole campus with, flyers in like several languages, not just English, Spanish, and Chinese, but Arabic and Russian and Cambodian and Tagalog, and we really got all over the place. And we got very few takers. We got about, initially we had about 15 people, but we expect about half to drop out. That's just normal life. And I'm just sort of wanting to make a plug to any providers here. If there's a way we can come up with a more robust kind of referral process, that would be really, we have this resource and it's plugged into the Wellness Center, and I wanted to just say that in terms of the social support and the peer education that happens. What we do in the class is we have the participants who've taken other wellness classes demonstrate like Zumba or demonstrate salsa. And it's a really great sort of connecting people on a social level, and we know that kind of learning is really effective and powerful. So I don't know if there's a way we can take what we've got going at the hospital and make it more kind of engaged with primary care docs to make referrals and to make that referral really compelling and not just a suggestion, but something even more.
Did the students that you get, did they come on their own, or did a provider refer?
They come on their own.
But they responded to the flyer.
Yeah, but we sent the notice out to every, clinic and medical director that we knew. We just didn't get any follow through from them. So the most of the people that came from flyers that we posted.
You were going to say something.
Well, I was going to ask a question very similar to that, which is sort of I like the beauty of the sort of separation to some extent from the medical side. I feel like what you were saying about the things that people say being separate from what you would hear in mobile land because of the safety. And I wonder how much the dynamic, because I was thinking, what a great model if I could refer, I didn't even think of referring folks to ESL classes. How would I have that conversation? It was sort of going through my head of how you do it in a way that's not stigmatizing, how I'm not, how I say I'm committed to taking care of you, whatever your language abilities, but wouldn't this be a wonderful thing, because I've heard these wonderful sort of the empowerment of this, and then thinking how I would say it from my position and what I would be thinking in my brain as I sort of talk myself out of it. And, because I'd be worried about people thinking that I was judging, and the beauty of the self-referral into these programs and the opportunities that they could feel free to talk about whatever they want, not what I sent them for.
Right.
And so then I was trying to figure out what would be a good model for how a traditional healthcare system could engage with ESL, or ESL within the healthcare sort of environment or the community center.
But the point is we have to, because a lot of people come to the hospital and they're not connected to a community resource. This is their community resource, and we're trying to. The Wellness Center is really the happy place on the campus. It's like people are always laughing and smiling and connecting with their peers, and it's also for patients and staff. So it's a way to shoot. We're all in this together. We're looking embarrassing, doing things we don't know how to do, like dancing or whatever. But also the other thing that we do, just so you know, we provide lunch for everybody, so that we know that lunch, having food makes it a social, comfortable, safe space for people. So I'm just saying we're trying, and we want to connect and make it a more collaborative effort.
I think what I'm saying is just that I think providers, we need the tools to know how to best make that referral in a way that feels safe and encouraging. I mean, I think some people do, but I think some people could say it in the wrong way, or would fear that they would say it in the wrong way. I would not know how best to do it, I think. I'm not talking about the traditional wellness programs, but I'm saying specifically, I think that's just what came through.
If that was on a separate e-referral, separate from wellness, would that be helpful? Or is e-referral not really where
I think it's the conversation piece.
It's the conversation.
Yes.
I think you said it really well. I mean, there is something really beautiful about this entire thing, because this is, what you were talking about. It's people who've chosen to come to ESL, and then the health piece is just sort of one module, one tool, one way to start, really meaningful conversations. Whereas but you're right. This is the community resource in some way for many people. And the question is how. But the referral from NIDA carries a little bit of a different message.
But sometimes don't we worry so much about offending or stigmatizing
Oh.
that we don't do?
No, we're not saying we're not gonna do it. We're gonna figure out how to do
I
it.
agree with you. I think that I'm sort of trying to say what the barriers could be at a provider level. And to some extent, I almost would rather my patients tell each other about it and then have that conversation in the waiting room and sort of.
Sometimes our job is connecting our patients to each other because they don't naturally have a mechanism to do that sometimes.
I think for me, and that the key is because I've gone there and experienced it, and I feel like it's a lot easier for me now to talk to people who I think would really benefit from the program, because I can say, yeah, and then I went on this, on Halloween, and they made all these great little fun things that you could make at home, and they're very healthy, and they had a great video, and they do all these dance things, and if ESL is there too, it's just like a whole
promotional video.
Anyway,
How do we get it out there?
And I have to suggest that I have the opportunity to visit one of the classrooms with Anna and also City College. But what I found is that as a research tool, I think it's really interesting because it's like things that we found in a focus group in the ESL classroom was easier, just because the people were already into the topic, they were already prepared to ask questions and not the researcher coming to ask them questions. So it was really interesting how shaping even the value of knowledge for us was interesting to see even situations like I was amazed when they were asking questions like, oh, this situation about diabetes, is it true that it's an epidemic? Because we think that it's more about doctors that trying to sell us more medication. And so, and that was for me so important, because I said, that's why people don't want to go to the doctor first and don't want to obviously stick to the medication sometimes because they don't believe. And so there's so many situations that I think the ESL classroom is a natural place where they can learn and we can learn too. So I think that you guys are doing an amazing job.
Great. Well, on that note, you guys are doing amazing.
Thank you.
Thank you, Maricel.